What's up, you guys? It's your boy Miguel giving you your daily dose of radiation. In today's video, we are covering the best advice I would give myself for X-ray lab positioning. So to give you context, I am a night shift X-ray tech. Been doing it for 4 years. So, the lab positioning, which I believe is one of the most important foundations of the X-ray program and X-ray in general, because there is where you learned how to actually do your job, how to position the patients, and how to look at images and be able to essentially know, are they good enough for the rad? That's basically the gist of it. So there's like two sides of it. You have the actual performing it, where your teacher sits down and you and your buddy will essentially mock or mimic what a walkie-talkie patient would do. And there's the aspect of trying to remember how to position the patient, all the angles and the SID and stuff like that that's going on. And then you do that, let's say you do that good, and then you walk back, and then the teacher whoops out an image, and it's like, okay, we have a chest X-ray, and then there's a picture of a chest, and then the teacher will say, okay, explain some of the anatomy we see in the chest X-ray, and then you give them the whole little spiel of like APCs, 10 ribs for deep inspiration, fine lung marking, stuff like that. You do that, and then you walk your patient out. That's like what you get graded on. But like when you're in the lab doing the actual like learning process of it, I would say that try to find someone that has a little bit more time or is able to like kind of like work with you, as far as like, because sometimes the lab work comes outside of the regular classroom. It could be there either early in the morning before school or later in the afternoon. Sometimes, or there's certain days where the lab is open, so you could like go and try to learn more. I mean, during class you should have a set amount of time, but depending on how fast you learn stuff, if you're like me, you're gonna need a little bit extra time. I was in there a few times, like 2 to 3 times outside of the actual class, to like go and learn positioning, which, I mean, you can technically position on anyone. Is kind of fair game. Even if your partner doesn't have to be there, you can still mimic like how to position like anyone. Just as long as you have a little body, you just throw them up there and kind of position them. You don't necessarily need your partner. I mean, it'd be nice to have your partner, because then you already kind of get the gist of like their anatomy, how everything is, and you can kind of, I mean, they can't help you during the exam because they got to sit there like they don't know nothing. But you don't necessarily need your partner to do some of the core, but there's like a certain way that you kind of do it, or it probably make you less nervous when it is your partner, because like you already kind of like are used to them. What else you have? It's broken down into different little subsections. You have like chest and abdomen. You have, sometimes they do the extremities, so like the hands, forearms, humerus, shoulders, clavicles. You have like the lower extremity, could be another breakdown, and then like the skull is usually its own little entity, which, as you're doing this, the same categories of like on the bond trigger, you'll have different like the same units of concept. Like there'll be like the head, chest, all the stuff. You'll be learning the actual like descriptions of what it is, and like what you see in the X-ray, and all the other fun little details that you need for the board. We'll be following along there. That one alone is like really a big one, I would say, out of all the classes, because not as far as difficulty goes, because I say that when that's like the main aspect of our job is to do that. But the most hardest part to me was the memorization. If you have Bontrager, if you look at your books, there's, I don't have mine with me, but there's like a little box. I call them, they're called the pink boxes, that shows like on an AP view, it'll show like, okay, this is what you see. This is the SID. This is the collimation. This is how an optimal image looks like. You have those. So for every single view, so let's say it's an AP, there's a box that describes it all. And then oblique, there's a box. A lateral, there's a box. So on each one, they're all relatively the same until you get to the obliques and the laterals. Because on those, certain anatomy will be seen different. Like, maybe some of y'all aren't techs or are going to be techs. So AP, you just put the hand like this, okay? Already, all these fingers are all the same. Except your thumb, you see how it's kind of already just naturally tilted to the side. So it's already at an oblique. So when you do the oblique, you're kind of like this. And then it's already, your thumb, that's like, I guess, like is slowly becoming more AP. So and then on the lateral, when you're all the way on the side, it is, your thumb is already in a complete, like, well, PA view, AP, whatever one you want to go with. So like, it's different views. Every bone is in a different view. So like, they may ask you, okay, on a hand, how's your thumb positioned for a true lateral? Da-da-da. And then you're going to show them, well, you're going to describe them how it looks like. And then one of the obliques, like they're going to ask you, how do you know if it's properly oblique? And it's mainly because of the joint space and how it's open. So there's that kind of like information that, to me, it was more harder memorizing all that. I mean, because you have to memorize for every single body part. So like from your finger, hand, humerus, wrist, forearm, shoulder. I think the whole upper extremity was like you had to tell them. So you had to like memorize all the boxes, actual performing it, and then telling to your teacher. Because like usually she'll just pick one, and ours would just pick one. Like if I had a hand, she would either pick like AP, oblique, or lateral, whichever one she wanted, to tell us what kind of view and how, like what we saw. And then sometimes she would throw up their images that weren't optimal and be like, okay, how would you correct this? And then you'd give them the whole little spiel. Which, once you're out there in the workforce, it's a little bit different because you don't exactly have every patient isn't walkie-talkie. You have patients that are maybe, especially if you work in the emergency room like I do, those images, sometimes you will not get textbook images because of the way patients are hurting, the way, like if they got hurt, if they're in pain, they can't always do, but all you can do is do the best you can. Sometimes you have to shoot, like, let's say it's a lateral, right? They can't always go like this. Okay, this is how it's supposed to be like this. Sometimes you may have to like reverse fan it and fan it like this. So there's different ways to get it, especially because sometimes the way certain stuff are broken, they will overlap or they can't really move. So let's say the image you take, you want to see like the pinky, right? But it's being overlapped. So like you can either curve it, like do more like this or more like this. It all kind of, you may have to do different views to be able to get the same, like the pinky. And usually the rad will understand. I've never had a problem as long as like you take like if something's broken, you already know, like in the deep, like in the back of your mind, okay, we will try to do the optimal picture, but if you can't, we're going to just try to take other views a little bit different. Maybe you have to document it, how to get the image for them to see what they got to see. Because at the end of the day, as you learn in school, you need an AP and a lateral bare minimum for every single view. Because you would think as a student, oh, well, you can just, sometimes, like on the AP, the image, like the bone, the way it's cracked, it'll look fine, but on the lateral, you'll be able to see that it got displaced or it got broken different. It makes a big difference. Once you're out there working in the field, you'll be able to see, and it does make a difference. And some of your doctors will just tell you, oh, you just the AP's fine. And not always. The rads will usually want always 2 pictures to be able to get optimal, because sometimes the rads will be like, hey, where's my other picture? I need my other picture, even though the doctor said in the ER. So they don't always know our protocol. For certain things, like for shoulder displacement, and they're going to pop it back in place, usually it is just a 1 view because they don't want you to like move it and jerk it around to like pop it back out. But that's outside of the actual lab. I'm just telling you real life experiences here. But yeah, it's been your Miguel. See you on the next one.